we were in this position and we got under the 2, 3, 3, 4, 4, 5, and we just increased the lordosis at that point, and then with this hand it sort of did that, and this hand flicked back there. It's the same technique in essence, except it's being applied in this position of major side bend for the rest of the neck to lock it, and it's being applied at the AA joint. So I am under the atlas with this finger here. So I'm under the atlas with my index finger on the left-hand side. The right-hand side is holding the side bend of the rest of the neck in essence. Because I'm rotating this way and because I've got a side bend all the way through the neck, I'm still in the congruent movement for the upper part of the cervical spine at the craniovertebral area. So the technique is to simply come into this position, a little flick in that position like that. That would be it. And Chris has moved on this side. So you see, I'm not generating a fantastic amount of rotary torque here. I'm in this position, I don't have a tremendous mechanical advantage, and it's just that. It's just a degree or two right at the limit of the range of motion. And so this is the rotary technique I would suggest we should do if we're going to do one. I use it quite frequently. I've never had a problem with it, but I only do it when I really feel that it's the forward gliding one that's significant. Now, in the past that wasn't the case. We used to have this idea that we get into the side like this, and if there is a stiff joint, whichever one is stiff will bear the brunt of the problem and absorb it. And the other one would still be sort of free to move, but we had not taken into consideration the fact that the stiff one becomes the axis of rotation. We sort of still took up that it was in the center here, and one of these was mobile and one of these was stiff, okay? And so this is stiff, I'm doing that, so this is the one that absorbs it because this has still got freedom of movement, but we know that's not true. It moves out to the stiff side, that's the problem. But we hadn't considered that. We just didn't know anything about it. Now we do know. It would be unconscionable not to take those principles into operation. And so that will be the technique that I would like you to do now. And just remember, even with Chris, with his stiff neck, so long as I can hold him here. Now, I'm pretty certain that, who's fairly mobile here? I don't want to manipulate you, but I just want to put you in the position. Come on, Alexa. You would see in Alexa a different position that you saw in Chris. Chris, I was here. Now with Alexa, I would probably have her head over there because I would have to use that to take up the side bend. Then I just look at that motion and then it would just be a little flick in that position. And you can see how controlled it is. That would be it, maximum. And I would hold it there. Just keep your eyes open, my dear. Look into my eyes, but don't stare at me. Okay. And relax. We don't want it to fix because sometimes people can stop nystagmus by fixing on a key point. So you kind of want them to look a little bit dreamy. Okay, so you can look at me and look dreamy. Give me a thrill. Okay, so here we go into this position and I just ask her just into that position. You see, when I'm testing, then I come off a little bit. See how that would be the technique. And we've tested it just about in that position as far as that vertebral artery is concerned.
Now, if you couldn't get all the side bending because of the lower joints.
Which was like Chris.
Okay.
So with him, though, it would still be locked up because essentially he must have some sort of degenerative changes. So I would expect to be there. I would expect to have a little bit more rotation there, like this. But my movement wouldn't be from there to there. I would have got the barrier a little further around with Chris, whereas with Alexa, as you see, if I get her head here, that's the barrier there. And the real skill is holding the side bend like that, so that when I do it, I don't do that and come out of that side bend. That's the real skill with this technique. And it's a very, very elegant procedure. Shall we try that? Let's get at it, these things. Okay, thanks.
No risk of losing it.
Hit any key to continue. Yeah, right. Abort, escape, and what's the other one? And none of them ever seems to work. You're pressing these things. No way. Okay. Right. What we're going to do now is to just take our minds away from the cervical spine and from the craniovertebral area, and we're coming on to the lumbar spine, where of course a great amount of problem occurs. And I think there's no question that for most of us we do see more lumbar spine dysfunction than cervical spine. I probably see 40% lumbar and then, I don't know, 30% and 30% thoracic and cervical if I were to look at my whole numbers. But the lumbar spine is a major problem, and we really do need to sort out a few things. In our brainstorming session here, in our mind mapping, we need to get what we consider to be the key essentials for us to be able to do a release movement of a facet without any trauma or without any complications occurring with the discs. So what I'd like you to do in your groups now, and you can have 15 minutes at least to do this, because I really want you to sort of bring this stuff up from all of the courses previously. What are the key things that you consider we need to discuss and to talk about? I'll tell you one of them. It's how does the spine absorb rotation? Because rotation is going to be, regardless, a very important movement to do. It's the $1 million roll. Okay? This is how Boyd's going to get his Mercedes, okay, by doing lots of these things here. And it's important that we know all of the aspects of absorption before we kind of start talking about how important these are. Now, having discussed this, what I want to do with you is to discuss an article by Cassidy and Kirkcaldy-Willis. And indeed, over the next day or so, I've left it until now. In the first part of the book, there is an article on the use of manipulation and the principles of manipulation written by Kirkcaldy-Willis, who was the Professor Emeritus. Now, he was a very interesting fellow. He's the Professor Emeritus at the University of Saskatchewan. He was a guy that went to Saskatchewan and went down to the physiotherapy department to speak to the superintendent or the director there, whatever the person was called, to see about whether manipulation could be done on patients. And he was told that this wasn't the role of physical therapists. So what did he do? He brought in some chiropractors to the department. And David Cassidy, who has been very instrumental in the development of modern chiropractic, was one of those guys. Moreau, there's a few of them, and they have been able to do what physical therapists and manual therapists should have done if they'd had somebody that was a little bit more forward thinking in that department. So Cassidy has brought out an article in the last edition of the Journal of Manipulative and Physiological Therapeutics talking about side posture manipulation. That's not side flexion, it's just laying the patient on the side, and these are patients with frank disc lesions as seen on CAT scans. And all of these patients were CAT scanned before, and all of them were CAT scanned afterwards. And the interesting thing is that they all received a daily manipulation for 3 weeks or something, and it made a huge difference in most of them. But the funny thing was, it didn't alter the CAT scans very much. And yet these patients became functional and pain-free. And so we need to look at these principles, because he said that we should re-examine what we are doing when we do a rotary manipulation as it is, as you will see, and whether it is as dangerous as we've always thought about. And so these are things that we should consider this afternoon, and then we'll do the many techniques that exist here. We'll certainly sort of try and split it up into 5 or 6 techniques, with then a few additional techniques for getting mobilization and with hypermobility. It's going to bring up some challenges for us to look at coupled and combined motions, at non-congruent and congruent locking, and we can have a little bit of fun with that. We can try and see if we can come up to some conclusion this afternoon, and of course this is never very accurate scientifically, I suppose, but to try and look at the side flexion and rotation freedom. If we can discover if there's any arguments about what are the coupled movements that occur in this area of the spine. So all of the biomechanical principles, the stuff that you get from the scanning examination, the way that the spine handles torsional strains, all of this should be part of the files that you want to put up to discuss with your partners here. So why don't you have a 15-minute sort of session on this, trying to just see where we should be going for the rest of this afternoon. It's very important stuff, this, so let's just have a mind map. Pages on the side, very good. No linear thinking now. We want random thinking now.
Just start with torsion.
What is the congruency and non-congruency of movement in the lumbar spine? Let's talk about that for a minute. Ralph, the honor is to you.
Quite a bit of disagreement as to what takes place together in a neutral spine. When the spine's in extension or flexion, then there's more agreement, but don't ask me what that agreement is.
Can you all hear what Ralph is saying here? What heresy Ralph is coming out with here? Can you all hear this?
As far as positioning in congruency or non-congruency, side bending and rotation to the same direction would be considered congruent.
Congruent.
Yeah. Side bending and rotation in opposite direction would be non-congruent.
In what positions?
In either flexion or extension. Because you could be side bent right in extension and left rotated.
So what you're telling us then, if they're non-congruent, that these are not the coupled movements?
If they're non-congruent,
Yeah.
what are not coupled movements? I'm not sure you're...
Well, you're talking about coupling, aren't you? You're talking about the relationship between side bend and rotation. And if we side bend, a certain rotational movement goes with that. If we force the rotation to be inappropriate as far as that side bend is concerned, that's what I call non-congruency. Okay?
Yeah.
And that's what we call locking. And that's what previously was called facet locking. Okay? Or non-physiological locking. Okay? And this is what we're talking about now, and this is going to be an absolutely fundamental here to understand this. So let's just put up on the board what we think about with this this coupling. And I'm going to put up the thoracic spine, and I'm going to put up the lumbar spine, and let's put up here what's happening in neutral, in flexion, and extension. And the thing we'll talk about is side flexion to the right. What is the rotation that goes on with side flexion to the right? Now let's talk this in your groups, and then we'll ask the groups for their contribution to this. So the problem I'm talking about is in this position, this position, this position. What happens as far as rotation is concerned when I side flex to the right in the thoracic spine and in the lumbar spine? Let me just focus you on that for a minute. So just decide that in your groups, and then we will take Ralph off the hot seat and ask all the groups to put up their contribution.
Some controversy, but we feel that at least in the lower thoracic and lumbar spine, from a neutral position, at side bend and rotation occur to opposite sides.
Okay, so you'd like, so here we are in neutral, we would be going rotation right. And how about the lumbar spine?
He said opposite.
Oh, sorry, rotation left, okay. And okay, rotation left. Thank you. Now, what about the rest of you? Are we going along with that? That when we're in the neutral position for the thoracic spine, apart from the top 2 or 3 which behave like cervical vertebra, that the chances are that the side bend and the rotation take place opposite sides. How about you, Ralph? Not too bad on that. All right. Now let's go into flexion. What is the situation as far as flexion is concerned? Kelly, your group. Same side. Oh, not the same as this, the same side. So we'd have rotation right. And how about the lumbar spine? Same. Rotation right. Okay? How about the rest of you? What's the consensus on this?
Perfect.
Perfect. All right? Now then, and your group for extension.
Well, we hadn't really totally agreed with that flexion thing, because then we got into the latection, rotection, which initiated it in thoracic as to which way it goes.
Okay, I have no idea. No idea. And what we should do is we should get people down on the tables. We should try and energize a flexion and a side flexion and see if it makes any difference. That's what we should do. Might make a difference, I don't know. It doesn't seem to make any difference to me, so I've abandoned all that myself. Perhaps I've got to relook at it, so that's good. It's a challenge. All right, so you've got some kind of a complication in this one as to the initiation in terms of this latection and rotation. Yeah, I don't know whether you're going to find latection and rotation anywhere in terms of standard biomechanical books. It comes from the old work of Hoover and the original osteopaths. And the osteopaths as a group have abandoned it. Now, whether we have resurrected it again, and we should have done this, I don't know myself. But it's going to be interesting to see what difference it makes when we start into doing double locking. If we've now got to consider whether we are putting in the side bend or the rotation first, it's going to be a further complication which should add a little challenge to this afternoon. That's going to be great, all right? Now then, how about extension? So you've got the same side. So you would say rotation to the right, rotation to the right. Both areas? How about the rest of you?
Not sure.
So some say same, some say opposite. Who says the same? Okay, so there's some small percentage in here. You may be dead right, of course. We don't know that yet. And the others think it's the opposite side. All right? Now then, when we look within this group, notwithstanding whether those things are right and wrong, would anybody else like to say anything about it? Any odd spots here and there?
The important thing is to test it for each person.
L5S1 is supposedly more controversial than...
Okay, so that's certainly a problem that we have to think about, L5S1. Yeah? What's the effect of having hypermobility and instabilities?
Changes them.
Yeah, it makes it very indeterminate as to what's happening. And very often you see what's often called in X-ray movement pictures paradoxical movement, where somebody's bending forward and one joint goes into extension. And you see this in some of these rotation side bend studies. I meant to bring I knew there was a reason why I'd got Bogduck and Tomy's book with me, and I thought this morning, I'll read a bit of that, and I thought, oh no, not bother, I know that. And I know why I brought it, because I was going to read a paragraph out to you. And when this latest book came out, I thought, right, this is the good thing. For two very good workers, for the very last time, this controversy has now ceased. We'll know what the definitive answer is. So I look in the back, coupled movements, it's there. So this has got to be the answer. Look at the page, turn the page up quickly with great excitement to see that this paragraph says that the problems of assessing side flexion and rotation coupling are enormous, and that it is not possible with any clarity to state what actually happens. And anyway, it is of limited clinical significance. Limited clinical significance when we use these principles to try and lock and localize. So we're still struggling. However, I would think that if you looked at just about every modern book, okay, the consensus, certainly with the neutral position, is that we get an opposite rotation side flexion relationship. That in flexion, disregarding this one, we get a same relationship. And this one, on the whole, from my readings, is that we get an opposite relationship. Now, what I'd like you to do is this. Let's just look at something that's easy to do. Now, let's argue about it. Let's look at something that's easy to do. What I'd like you to do is to go into the thoracic spine, let us say at about T8 or T9, something like this. And I'd like you to place the T8, T9 in flexion. And then I want you to do the side flexion, as we've got it here, to the right. And I'd like you to tell me whether the rotation to the left or the rotation to the right goes with this. What movement is freer when we've set this up? Because if we use the non-congruent movements, this is going to basically be stable for that opposite, that non-congruent movement. And this is what we've got to utilize when we're doing these long lever procedures. And with Olaf Evian, he's got his double locking techniques from below and from above. And we are going to have to utilize those this afternoon in sitting and in lying. Now, if we're going to introduce a further principle of latection and rotection, it's going to be really difficult as to sorting this out. So we'll kind of leave that alone for the time being, because I honestly don't know the answer to that one. Therefore, I would be foolish to get into discussing it if I don't know the answer. But I think when we look at these principles, we'll see that there's certainly freedom demonstrated and stiffness demonstrated. And that's perhaps what we should go with. So let's take the thoracic spine, and I'd like you to look at it in sitting in both the neutral, the flexed, and the extended position with side flexion to the right, and let's have a look at where the stiffness is. Do we get rotation to the right facilitated by the side flexion to the right, or do we get it resisted? That's what we need to know. And that should give us a good indication as to where we should go with this. So there's the challenge. So instead of writing here, we're going to experiment. Let's see what happens here. No. You don't need to get sat down here, because we're going to go on with the controversy. Here is the exercise, all right, that you are going to do. What I'd like you to do is this, because this is going to be so useful to us when we start manipulating and we start laying the patient down and doing a whole variety of things, okay? I just want you to sort of be able to do this. So I'd like you to take the position of sitting like this. And what I want you to do is to assume that we've got at T8, 9, we've got a right rotation stiffness. Okay? And it's more stiff in flexion. Now, I'm not going to even use the term non-congruent and congruent, okay? I want you to use above the most rigid lever that you can produce. To me, that is non-congruent locking. If it's got a little bit of freedom, that is congruent. That's how I look at it. And then what I want you to do from T9 downwards, or let's say from the sacrum here to T9, I'd like you to place that in the most optimum position to resist rotation to the right and flexion. Okay? Have you got what the thing is? So we want you to use a rigid lever above to include T8. T8-9 is the problem. So we want you to then go up to T9 and make sure that the lever from the sacrum to T9 is in the best position to resist that rotation. In other words, if you get down and it's gone through 8 and 9, we don't want it producing rotation to the right and flexion in this lever, which will compensate for the stiffness at this one. That is the question. Everybody understand it?
Do we have to do it in sitting?
Yes? That's the only position I can understand it. No, it's good to do it in sitting to start with.
So we want most rigid or optimum?
Well, most rigid. By optimum, I mean the best resisting lever.
Just ask for a hint. You lock them in place.
The principles of Evian, but when we're talking about a lever, all right, and you've got a stiffness at a segment, the lever that you're using has to have at least 2 of the flexions. That means either the side flexion or the rotation or the forward flexion. It wouldn't be possible with this top lever here to hold the lever in extension and then produce flexion with that moving lever at T8-9. You'd have to have that lever, the top lever, in flexion. And that flexion has to go down into that joint because that's what we found. It couldn't rotate to the right in flexion. So one of these movements, or 2 of these movements, have to be included in that lever, which gives you the option only of looking at the side flexion. And then you can decide on this bottom lever what you're going to do about it. All right? This should keep Bob quiet for 5 minutes. Calling you Kelly?
No, you've been calling Kelly Sandy.
Oh, have I?
Called me Sandy. That's okay.
Okay.
Just don't call me Bill.
Okay. That's good. That's good. That's good. Let's pull that down just a little bit now. Okay. Let's just talk about the principle that we tried to do here so that we don't get too sort of confused with this to start with. The problem that we discovered was that Sandy could not flex and rotate to the right. So we have got to do flexion and rotation to the right. And if we're dealing down with a lever down here, that's a jolly long lever to deal with. So we want this lever reasonably rigid. Otherwise, even if we put it in the non-congruent or in the congruent movement, we're still going to have all that give that is quite typical of any joint that's taken to its end range and we do passive. We've got that little bit of passive give, so we want to try and eliminate it. So we're going to place that lever in its non-congruent position. So if it's flexion and rotation I've got to get, I've only got one alternative. What do I do with the side flexion? And I go opposite, don't I? So that I'm going to come into this position, which will rotate her this way, which makes her resistant to rotation to the right. So that's what I would do. I'd go into the non-congruent lever for rotation to the right. Now the question is, what do I do with the lower lever? And if